Good afternoon, friends. Welcome to my channel, Pediatric Classes. I hope all of you are staying safe. Today, we are going to discuss about the comprehensive guidelines in the treatment of COVID-19 in children and adolescents. This discussion will be based on the recent document released from the DGHS, Ministry of Health and Family Welfare, Government of India. So with these words, I'm going to share my screen. Before that, if you have not subscribed to my channel or viewing this channel for the first time, I request all my viewers to please subscribe to the channel. And let me start now sharing the screen. Okay. So this is a very good document. It's freely available overnight. Requesting all the viewers to go through the document also. First of all, let me thank the Director General of Health Services, Professor Dr. Sunil Kumar, and also all the list of experts or contributors who have actually contributed a lot in bringing out this wonderful document. Thank you so much, dear sirs, madams, for this document. With this intro, let me actually take you through the major changes in this document. The title of the document has been changed from the comprehensive guidelines for the management of COVID-19 in children below 18 years to comprehensive guidelines for management of COVID-19 in children and adolescents. That means they have included the term adolescents also. And the use of, and second change is the use of antivirals or monoclonal antibodies is now not recommended for children less than 18 years, irrespective of the severity of infection. Third is about the MISP. So they have told us clearly that we have to exert maximum caution while interpreting only the isolated increase in the COVID antibodies. The CRP level used for the diagnosis of MISP has been revised as more than 5 milligram per deciliter. The next change is about the use of steroids. They're very clearly told the steroids should be tapered over 10 to 14 days, subject to the clinical improvement. Then other thing is about the use of anticoagulant, which will be the revised one, which we will be discussing in the further slides. And a new section on the post-COVID care has also been included. So these are the major changes actually which has come. Now, sorry, there's a slight technical problem. I'll just get you back to it. Okay. Okay, now this is one thing. That is a COVID appropriate behavior is recommended to prevent SARS-CoV-2 infections. There are three things. One is about the 3 W's and 2 V's. What are the 3 W's? So one is the watch your distance, that is more than 2 meters should be maintained. Wash your hands and wear a mask. And 2 V's are nothing but one is ventilation. They are recommending open spaces rather than closed or poorly ventilated areas. And other thing is about vaccination. So this is like 3 W's and 2 V's. Now, going into the topic as such. So these are the COVID-19 symptoms in children. At a glance, if you see what are the symptoms which we see, we get, there are lots and lots of symptoms which we actually get it. So they include fever, sore throat or throat irritation. Then we have diarrhea, cough, body ache or headache, anorexia, nausea, vomiting, rhinorrhea or running nose, malaise or weakness, loss of sense of smell and or taste. As you all know, the Omicron variant is associated with comparatively very less things of loss of sense of smell and taste compared to the Delta variant. But the sore throat in Omicron, that is much more than the Delta variant. Maybe in some other discussion, we'll be discussing about what are the exact differences between the Omicron and the Delta variant. So sticking on to this document, they have divided the whole things into 4 categories. One is symptomatic, other thing is mild, then is moderate and severe. Please note here, the major things are differences are related to the respiratory rate and the SpO2. So what is this respiratory rate thing? So asymptomatic, they will have a normal respiratory rate. normal SpO2 of more than 94%. They will not be having any grunting, lethargy, or seizures. Whereas in a mild case, again, the respiratory rate and normal, SpO2 is normal, everything is almost normal. But whereas in a moderate case, what happens is there is rapid respiration. As you all know, it is less than 2 months. It is more than 60 is abnormal, 2 months to 12 months, it is more than 50 is abnormal, 1 to 5 years, more than 40 is abnormal, and more than 5 years, it is more than 30 is abnormal. So this is a tachypnea. The tachypnea in a moderate case may or may not be associated with a loss of SpO2 or decrease in SpO2. So what happens is they can have a normal SpO2 or an SpO2 in the range of 90 to 93%. There won't be grunting, lethargies, or seizures. Whereas in a severe case, there is tachypnea, there is a desaturation with an SpO2 less than 90%, with or without grunting, lethargy, or somnolence, or seizures. I'll be discussing in detail about each and every scenarios shortly. So this is one diagram or one single document which we can all take a Xerox or print out of it and just keep it on your tables. So that is a very good ready reckoner. So here what I have done is, there are 4 categories. So I have actually taken into different slides because I know this is very difficult to read through this document now in the Zoom. So now it is asymptomatic one. What is an asymptomatic patient? So asymptomatic patient means it's a suspected contact, either RAT or RT-PCR negative or not available, whatever it is, but it's a suspected contact, or the patient is incidentally detected. They're not having any symptoms, but then happened, they just the RAT and it came as positive. So the thing is, they need only home isolation and teleconsultation SOS. Infants and young children need to stay under immediate care of parents or guardians. This is the main space, like no specific medications required. Just continue the medication if they're taking it for some other conditions. Promote COVID-appropriate behavior. When I say COVID-appropriate behavior, remember the slides I told, 3 Ws and 2 Vs. Okay. And next is about the fluids and feeds. Ensure adequate oral fluids to maintain a hydration and give a nutritious diet. Advise all them to stay connected. What we require in this time is the positivity. So they can actually talk over phone calls or videos, etc. Parents or caregivers should be advised to contact the doctor in case of appearance of any symptoms. There are no investigations required. So other thing is about the mild cases. So when I say mild cases, they are not asymptomatic. They are almost like asymptomatic. They are having some symptoms. In asymptomatic, the patients were not having any symptoms, whereas in a mild case, the patient may have some symptoms like sore throat or rhinorrhea, cough without breathing difficulty, with a normal SpO2. Okay, so other symptoms, I have already told you. I have put the slide just few slides before to see the other COVID-19 symptoms. That includes none other than diarrhea, loss of smell, and other things. Now, then what is the thing is, it's again home consultation, or they can go for a COVID care center. And the mainstay of treatment is only supportive. So what we give paracetamol for fever, 10 to 15 milligram per kg per dose every 4th to 6th hourly. As you all know, especially the Omicron variant is associated with high spiky fevers. So we may need to give it every 4th hourly also. For cough, give throat soothing agents and warm saline gargles. And about the fluids and feeds, we have to ensure oral fluids to maintain hydration and also give a nutritious diet. No other COVID-19 specific medications are required in a mild case. Antimicrobials not indicated. Maintain a monitoring chart, including respiratory rate. I told you the main thing is respiratory rate. Count it every 2 to 3 times a day. Look for chest in drawing. Feel the extremities, whether it is cold or not. Check out for the urine output, oxygen saturation, fluid intake. How is the activity level, especially for young children. Promote COVID-appropriate behavior, which we already discussed. 3 Ws, 2 Vs. Advise the older children and family to stay connected and engage in positive talks through phone, video calls, etc. Parent or caregivers are advised to contact the doctor in case of deterioration of any symptoms. Is there any investigation required in a mild case? No, there is no requirement of any investigation in a mild case. Coming to the moderate cases, what are moderate cases? Moderate cases means the patients, in addition to the symptoms in mild case, they may have a tachypnea. You have to check out for pneumonia, which may not be apparent. What we can do is we have to check for the respiratory rate. So I told you initially there are the cutoff of is less than 2 months, more than 60 is abnormal. 2 months to 1 year, more than 50 is abnormal, 1 to 5 years, more than 40 is abnormal, and more than 5 years, more than 30 is abnormal, and with or without a saturation in the range of 90 to 93. That when I say that, cases with tachypnea with a normal saturation and cases of tachypnea with a desaturation between 90 to 93, both are included in the moderate category. For other symptoms, which I already told, in the glance of diarrhea, other nose or smell, all those things we also have to check out. What we should do, we have to admit them in a DCHC or in a COVID-19 hospitals. What are the basic investigations required is, one is a CBC, including ESR, check out blood sugar and a chest X-ray, because in moderate, as I told, there is a tachypnea. We have to rule out any viral pneumonia. Just do an X-ray also. So what is the treatment in a mild moderate case? Start oxygen if SpO2 is less than 94%. Maintain the saturation between 94 to 96%. Maintain the fluid and electrolyte. Maintain the fluid and electrolyte balance. Encourage oral fluids. Small baby infants with breastfeed solution encourage. Otherwise, we have to ask them to take more and more oral fluids. If the patient is not taking a proper oral fluid intake, start on IV maintenance therapy. Steroids are not required in all children with moderate illness. They may be administered if you feel that it is rapidly progressive. Fever with a temperature more than 38 degrees Celsius or more than 100.4 degrees Celsius, yes, we have to give paracetamol 10 to 15 milligram per kg per dose every 4th hourly or 6th to 6th hourly. So that's a small typo error, not every 4 to 6, it is 4 to 6 hourly. I'm sorry for the typo error. And antimicrobials to be administered if there is evidence or a strong suspicion of superadded bacterial infection. Please see the antimicrobial usage, which I will discuss later. Supportive care for comorbid conditions required. Now, what about the severe thing? Severe, as we saw in the previous few slides back, I put that tabular column. Severe is none. Don't worry, there is tachypnea, but there is a desaturation of less than 90%. See here, SpO2 is less than 90% on room air with any of the following, like either a severe pneumonia or an acute respiratory distress syndrome or septic shock or multi-organ dysfunction syndrome or pneumonia with cyanosis, grunting, severe retractions, lethargy, somnolence or seizures. For other symptoms, again, those symptoms of COVID-19 may be there. So the differentiating feature is there's a saturation loss of less than 90% with associated symptoms of pneumonia or ARDS or septic shock, etc. We have to admit them in a high dependency unit or ICU of a COVID-19 hospital. What are the investigations required? The baseline investigations include CBC, including an ESR, blood glucose, CRP, LFT, kidney function test, the serum ferritin, D-dimer, and chest X-ray. So these investigations are required. See there, in severe case, if you suspect, you have to do ferritin and D-dimer. So all the other, along with other things. So what is the mainstay of treatment? Immediately you have to initiate oxygen therapy. My target oxygen level is 94 to 96%. Maintain the fluid and electrolyte balance. Corticotherapy is required to start the patient on steroids. Anticoagulants may also be needed. This will be discussed in the subsequent slides. So in case of ARDS or shock, initiate necessary management, which will be discussed in further slides. So these, based on the document from Ministry of Health Family Welfare, they have wonderfully given it. Again, I am requesting all my viewers to go through the document. I have just taken the points from the guidelines. It's a very good document. Antimicrobials to be administered if there is evidence or strong suspicion of superadded bacterial infections. May need organ support in case of organ dysfunction like renal replacement therapy. Is there any requirement for CT chest? It is not indicated in the diagnosis or management of COVID-19 infection in children. Consider CT only if there is no improvement in the respiratory status. As of now, in the absence of safety and efficacy data, which I have already started in the first slide, that is the use of antivirals like remdesivir, favipiravir, molnupiravir, fluoxamine, and modern monoclonal antibodies like sotrovimab, casirivimab, imdevimab are all not recommended for the children less than 18 years, irrespective of the severity of illness. Decision for home isolation of children with immunocompromised state or chronic illness should be taken after proper assessment and discussion with the family. And children with comorbidities should continue to receive appropriate management also for their underlying disease. So these things are general things which I have discussed in this slide. So in the previous slides, we have actually discussed this slide. This is about the COVID-19 symptoms and also how to differentiate. Now, I hope you have got a very clear picture about what are these different categories and what are all these color codings. And this is about the treatment, which I've discussed in each differently in different slides. So these two are very good tables. Actually, we should take a printout and keep it. Now, I told you ARDS will be discussed. ARDS, in according to the document, they have actually divided into mild, moderate, and severe. Mild requires high flow nasal oxygen. Start with 0.5 liter per kg per minute to begin with, and increase to 2 liter per kg per minute with monitoring, or go for non-invasive ventilation or like a BiPAP or a CPAP. In moderate to severe ARDS, yes, we have to consider a lung protective mechanical ventilation, which should be initiated with a low tidal volume, 4 to 8 ml per kg, with a plateau pressure of 28 to 30 centimeter water, MAP less than 18 to 20 centimeter, driving pressure less than 15, PEEP of 6 to 10 or higher. If it is severe ARDS, we may have to step up the PEEP. FiO2 of less than 60%, pseudoanalgesia plus or minus neuromuscular blockage, cuffed endotracheal tube, inline suction, heat and moisture exchange filters, all should be used. Avoid frequent disconnection from the ventilator circuit, nebulization or meteor dose inhalers. Restrict the fluids, calculate the fluid overload percentage, keeping it less than 10%. What about the proning? Yes, prone position may be considered in hypoxemic children if they are able to tolerate it. Another thing is about the daily assessment for weaning and early extubation. Enteral nutrition should be started within 24 hours and achieve the full feeds within 2 days. Transfusion if the hemoglobin is less than 7 gram per deciliter. If stable oxygen and hemodynamics and less than 10 gram per deciliter if refractory hypoxemia. When I say that, suppose a patient is having less than 10 and they're having a refractory hypoxemia, you transfuse. But the patient is having a good oxygenation and hemodynamics, we need to transfuse only if the hemoglobin is less than 7. What about the treatment of shock according to the new guidelines? Consider crystalloid fluid bolus, 10 to 20 ml per kg over 30 to 60 minutes with early vasoactive support of epinephrine. Start antimicrobials within the first hour after taking blood cultures according to the hospital antimyogram or treatment guidelines. Consider inotropes, milrinone or dovitamin if there is poor perfusion and myocardial dysfunction persisting despite the fluid boluses, or vasoactive drugs and achievement of target mean arterial pressure. Then hydrocortisone, what about the role of hydrocortisone? If it is a fluid refractory catecholamine resistant shock, please add hydrocortisone. But if you have already started the patient on dexamethasone or methylprednisolone, please avoid. Once stabilized, restrict the IV fluids to avoid the fluid overload. Initiate enteral nutrition as early as possible. Transfusion trigger, as discussed early, it is less than 7 if the patient is having a stable oxygenation and hemodynamics, and less than 10 if refractory hypoxemia or shock. So this is one proforma, suggested proforma, which is given in the document. I think the hospitals can modify it accordingly depending on the condition of the child, because this is a document, actually it is the 4th hourly monitoring is given. What we have done in our hospital is we have actually incorporated this data and all idea, and also we may have to actually add or rearrange this according to the hospital protocols. But this is a very good thing. They are having a name, sex, comorbid conditions, weather control, what are the drugs being taken, then the other things they are included, everything which I have mentioned in the initial classification, that is lethargy, what about all the work of breathing, temperature, BP, respiratory, chest syndrome, SpO2, physical activity, etc. Only one suggestion which I thought about this document is we could have added in such a way that all this heart rate, respiratory rate, BP, SpO2, it should have gone in a better order. So this, according to your hospital policies, you can modify it, but make sure that you are having a very good treatment monitoring chart for all the COVID-19 patients. That will really help them and help us to find out if the patient is deteriorating or improving, and will help us in the treatment. Now, what is the guide for using masks? This is a very short document. In that document, there's a small paragraph about it. The masks are not recommended for children aged 5 years and under. Children 6 to 11 years may wear a mask depending on their ability to use the mask safely and appropriately under direct supervision of parents or guardians. More than 12 years, yes, they need to wear a mask under the same condition as adults. Ensure hands are clean with soap and water or an alcohol-based hand rub while handling mask. What about the antimicrobial usage guide? So please remember, this is a viral infection. So antimicrobials have no role in the management of uncomplicated COVID-19 infections. Like asymptomatic mild cases, it is not required. But in moderate and severe cases, if there is a clinical suspicion, strong clinical suspicion of superadded infection, yes, you can add. Otherwise, we should not give antimicrobials. In septic shock, empirical antimicrobials, according to the body weight, are frequently added to cover all likely pathogens based on the clinical judgment, patient host factors, local epidemiology, and antimicrobial policy of the hospital. What about the use of steroids? This is a very debating topic, but the document says that steroids are not indicated and they are actually harmful in an asymptomatic and mild cases of COVID-19. These are indicated only in hospitalized, severe, and critically ill COVID-19 cases. Steroids should be used at the right time, right dose, and the right duration. So remember, when I discuss about the treatment, even in moderate case, unless the patient is rapidly progressing, we don't use a steroid. But recommended in case of severe and critically ill COVID-19 patients. Indications and recommended dose so may be used in rapidly progressive, moderate, and severe cases. I hope we are clear here. This is a very important point. Steroids are not to be used for mild or asymptomatic cases. Moderate also, and if it is rapidly progressive, moderate, or severe, we can use. Otherwise, not required. Dexamethasone and methylpred are generally the recommended ones. Dexamethasone in the dosage of 0.15 mg per kg with a maximum dose of 6 mg once a day, or methylprednisolone 0.75 mg per kg, maximum dose of 30 mg in a day. We have to continue for 5 to 7 days and taper over 10 to 14 days, depending on the clinical assessment on a daily basis. See this one, please remember, avoid the steroids in the first 3 to 5 days since onset of symptoms, as it prolongs the viral shedding. Self-medication of steroids must be avoided. Now, what about the use of anticoagulants? This is not recommended routinely, but all hospitalized children should be evaluated for the risk of developing thrombosis, and they should be monitored actually for the development of thrombosis. Prophylactic anticoagulant is indicated only in the following circumstances. Okay, one is strong family history or a personal history of thrombosis, or an indwelling central venous line and 2 or more additional risk factors, or 4 or more risk factors like predisposing risk factors to the development of thrombosis. So like personal history of venous thrombotic events, family history of first degree relativity, presence of central venous line, decreased mobility from baseline, burns, active malignancy, estrogen therapy, flare of inflammatory disease, morbid obesity, severe dehydration, recent surgery, trauma, etc. So if you're not able to remember all this, don't worry. You just can take the small thing and put a checklist. So when the patient comes, we just have to check out whether there are any risk factors. It's the best way to do it. Prophylactic dose of low molecular weight heparin, that is enoxaparin, 0.15 mg per kg twice daily till the child is discharged from the hospital. On suspicion of thrombosis, confirm by appropriate investigation and start on low molecular weight heparin in therapeutic doses. So we have 2 types of doses. One is the prophylactic dose that I told you. These are the above risk factors where we should start the prophylactic anticoagulants with a dose of 0.5 mg per kg, whereas if we have a suspected thing is confirmed, the thrombosis is confirmed, what we should do is we should actually start the patient on the therapeutic dose of enoxaparin, that is 1 mg per kg. That should be continued for a period of 12 weeks with monitoring. Children already on anticoagulation therapy may continue same unless they develop actively. Now, about the post-COVID care, children with asymptomatic infections or mild disease should receive the routine child care, appropriate vaccination, nutrition counseling, and psychological support on follow-up. In addition to the above, the children with moderate or severe COVID at discharge from the hospital, or parents or caregivers should be counseled, because there may be a persistence or a worsening respiratory difficulty. And they should also be explained about the indications for bringing the child back to the hospital. So we are explaining all these things to the patient. Another thing is children who develop any organ-specific dysfunction during hospital stay or subsequently should receive the appropriate care. So in this document, a specific part is devoted for the post-COVID care. So these are the major changes in the running document compared to the June document. Okay, so we have discussed except for the part in MISC. That discussion, I thought I'll put in another video because otherwise a video like this becoming so much and we may not be able to concentrate better. So that video will be coming out in another 1 or 2 days. So till then, all of you stay safe, and I really want to once again thank all the experts behind the this document. Thank you so much, and stay safe.